Welcome to the weekly Benefit Roast, featuring Benefit Indemnity Corporation's president, Rodger Bayne. Rodger has devoted more than 30 years to understanding and developing innovative health benefits plans for large groups and groups as small as 5 employees. Our moderator is Bob Graham. Take it away, Bob.
Hello and welcome to the Benefit Roast. It is July 29th, 2019, our last episode for July. Can't wait to get into this, but before we get started with the hot topic today, and I'll give you a hint, it involves some acronyms, but before we get started, let me just do a little housekeeping with you. If you want to contribute or participate in our discussion, you can write a comment, question, or concern in the chat box on the right of your screen. And if you would also like to be on air with us, we'll try to get you involved, but we've got a lot of people, and sometimes the technology of the chat functions for audio isn't as good as just writing in the question or comment. But if we see you and we can make it work, we will do it. With that, Rodger, we're going to talk about a really exciting topic today. This is one I don't know a whole lot about from your perspective, but I think I understand it from the traditional insurance perspective, which is preferred provider organizations. I practiced that all morning because I knew I would struggle, or as you like to call them, PPOs, but I wanted to say it out once. I think everyone has a sense of what they are, but you had some thoughts about these that were a little different than what I was expecting. So can you enlighten us today?
Well, I can, Bob. I mean, when you talk about preferred provider organizations, you go way
easy
back.
For you to say.
Yeah, you can talk about a PPO, and as a preferred provider organization, you go way back to the original days, right?
This was right after HMOs, right?
Oh,
PPOs were the child of HMOs, right?
Well, kind of. Actually, they were more like the angry kid brother.
Okay.
The HMOs came out with aggressive managed care and started beating up on the insurance companies. The insurance companies had to figure out a way to fight back. So here they are, the little brother, the PPO, that says, well, wait a minute, I can negotiate with doctors too, and maybe even better because I had more people covered today than the HMOs do. Even though they were coming on strong and growing, they were still new. And so the big guns said, let's organize doctors into a contractual relationship and get them to agree to accept certain fee structures so that we have a predictable number as well.
Okay. And we're in the late 80s, right? Early 90s at this point? Is that?
Yeah, late 80s, early 90s.
Okay.
I mean, I'd say probably late 80s was the beginning of the PPOs as I know it. Again, I got into business in 86. And in the early days, we were selling traditional plans. Just go anywhere. We pay usual, customary, and reasonable reimbursement rates to the providers.
The good old easy days, right?
Well, yeah, in a way it was easy, but it was easy because the rates were $35 a person, not $350 or $700 a person. So there was a whole different world. So anyway, the preferred provider organization, the idea of it and the intent of it, the whole purpose was to help manage care from a fee structure. So from a reimbursement structure, make sure that what we're paying the doctors is a reasonable amount. You know, there's a part of me that says maybe PPOs started before HMOs in the form of Blue Cross organizations. Right? I mean, so if you think about it, a Blue Cross organization was the same, and they were out there, and it was the doctors getting together at a meeting, deciding how much to pay themselves.
So we're talking about a time with set rates, really, is what we're really getting at.
Right, but what we're talking about also is as the HMOs came in, and it made it more challenging for the commercial carriers, again, to compete. The commercial carriers were competing with Blue Cross organizations by using these usual, customary, and reasonable rate schedules. So they pay the doctor the prevailing rate of what other doctors charge in an area, and they do the calculations from their database and some other standardized databases, and they'd say, okay, we're going to pay at the 80th or 90th percentile, and this is what you're going to get, doc. And anything above that, the customer has to pay, or you're going to have to say, just forget it. And that was, again, in the softer days when the numbers weren't as high. So
also was a time when the consumer had a sense of what they were investing in this as well. I mean, I can remember my parents had an HMO at one point. It was like, anytime you had a sneeze, you would go to the doctor because
Oh, yeah.
you weren't paying any more than you were paying if you had a broken leg.
Well, and oftentimes you had a zero copay for office visits, or even $2, even $5. But in the early days, it was 0, 2, and 5 was very typical for an office visit. So I actually had the first employer that I put into a triple option plan. And what that meant is they had an HMO, they had a PPO, and they had a traditional indemnity plan. And the employees could choose which way to go. And one of the front desk employees of this company enrolled in the HMO. And I got a complaint from the employer that he could not keep her at work. It was too cheap for her to go to the doctor. And she was always at the doctor's office. And she said, I don't know.
A hypochondriac's dream, right?
She said, I don't know if she was just lonely and needed somebody else to talk to or what, but I can't keep her at the desk because it was $2 office visits. I mean, so
that's the best story you've told in all the episodes we've done. That's my favorite story.
It was
so far.
A true story. It was actually a partnership between the Johns Hopkins Health Plan, Johns Hopkins Hospital created an HMO at the time, and American General, which was one of the leading commercial insurance carriers. They hooked up with a PPO. So you had Hopkins, you had American General with a PPO, and you had American General Indemnity. And that's what happened. It was one of the first, and it got destroyed by anti-selection.
Okay.
All the young and the healthy enrolled in the HMO. All the sicker and older stayed in the PPO or the indemnity plan where they can go see their own doc. And guess what? The rates weren't properly adjusted or weighted for it. So the insurance company, American General, got crushed while Hopkins made a killing. And so that just couldn't last. So the whole deal just ultimately morphs into collapse.
Okay.
So we've seen that happen a lot.
So why do we care about PPOs today, Rodger? We've gone a little through history.
Well, the reason we care about PPOs is because they had a very, very important and useful purpose in the beginning, and that was to help customers get the right pricing for their healthcare. You know, anytime an insurance company goes out and tries to save money by paying a doctor the right fee, they're really saving the customers money. You know, everybody always think, that we love to point fingers at the insurance companies being the big bad guys. Insurance companies will pass on any rate you want to pass on. Right? If you want to pay the doctor more, they'll charge you more. That's fine. But if they can help you navigate a way to pay the doctors and the hospitals a more appropriate pricing structure so that you get a better premium on your health plan, then everybody wins. So it's not always the insurance companies being the bad guy.
Okay.
And I'll show you some of that in a few minutes. So anyway, the PPO was designed to help do that. And that was really the purpose. And for many years, it did a pretty good job at that. It's evolved over time from a fee for service with a discount to flat fees on some things like capitation on primary care and then other things for that. So it evolved through a number of different reimbursement mechanisms or financing mechanisms and how to pay the doctors and providers. But ultimately today, what it appears to have happened is that certain physician practices and organizations and hospitals develop a reputation in their local market, right? Everybody says healthcare is a local system. It is not a national system. It is not regional. It's local. Everybody cares about their own doc and their own hospital, right? So if you're going to deliver a health insurance program, you better be focused on what's going on locally.
Even if you're a national company providing that,
right?
You've got, because local, I only go to the doctors and hospitals in my area.
Exactly. And so that's what makes it very expensive to administer health plans as well sometimes, because you've got to be able to have feet on the ground all over the country that is talking to hospitals, providers, and making sure you have all these deals.
And that would be expensive in New York and maybe not as expensive in Birmingham, Alabama.
Right.
Or vice versa, depending on the situation.
Depending on what's going on. Exactly. Right. And so all of these things. But what's happened now is because certain hospitals, I mean, come on, think about it. Mayo Clinic. You tell an employee you can't go to Mayo, they think, well, what are you talking about? It's one of the best hospitals in the world. You're not going to let me go there. So all of a sudden now the insurance companies have to keep Mayo on their side. And they have to negotiate with Mayo in good faith, but maybe have to pay them a little bit more than they should because they have a better reputation, whether it's earned or not.
Okay.
So that reputation warrants a higher price sometimes. And
can it warrant a lower price as well if a hospital or a practice has a lesser reputation?
Well, if a hospital has a really bad reputation, the insurance company could say, okay, you're not going to be in our network, and nobody would cry about it. But if you take shock trauma in Maryland, in Baltimore, if you take the shock trauma unit at University of Maryland Medical System.
For those of you who are not in Maryland, this is a system where they pretty much take the worst cases and have an incredible survival rate.
Right. And if you say we're not going to take them, we're not going to take that hospital, they're not going to be a participant in our PPO, then everybody gets scared. Because what happens if their family has one of those tragic accidents?
Okay.
And so you have this evolution over time where instead of serving the customer by really controlling rates, it's now, many of us joke tongue in cheek, that it is now a provider protection organization. The insurance companies are now coveting their relationship with the doctors and hospitals at a higher level than their own customers. And so fee controls and cost controls are losing grip. We don't have it anymore. What we're seeing is hospitals demanding higher fees and saying to an insurance company, hey, my fee is $50,000. You've contracted for a 40% discount off of that $50,000. So you're going to pay the remaining $30,000, period. It doesn't matter that it was a $900 titanium pin for somebody's back that you charged $50,000 for and discounted to $30,000. The $30,000 is what you're going to now pay because your contract with the PPO says you're going to pay 40% off of billed charges or 50% off of billed charges, or whatever that negotiated contract is. So what happened is there starts to be a backlash and starts to be a negative impact. Some PPOs refuse to allow you to even audit their hospital bills for their providers. They refuse that you can't go back and negotiate with the hospital further. It's disallowed in the contract. So if they approve something as a service to be covered, you've got to pay the bill minus the discount. And they profess discounts at 52%. And we've got a case right now that's ongoing. It was a pair of twins born prematurely. The claims have totaled up over $900,000. The discounts that were professed by this network were 52% savings on everything. Well, in this $900,000 claim, we're only seeing 19% savings.
That's a big difference. That's a couple $100,000.
That's $300,000. That's a big nut, because the promise of the PPO on discounts are stated in average terms. Everyday tonsillectomy, yeah. But if it's this unit or this unit or this procedure, well, that's not as deep a discount. So you get into scenarios where all of a sudden an insurance company can no longer predict costs. And that's the most expensive thing there is in health insurance. If you remember when Donald Trump threatened to remove subsidies for the cost sharing under the ACA, everybody's rates went way high because the insurance companies could no longer predict what their exposure would be. Well, that's what's happening in the PPO market today. And if you can't predict, you have to rate for the worst case scenario. And rating for the worst case scenario is expensive, and especially in the fully insured market, where if you pay too much, you pay too much. You don't get anything back.
Right.
At least in the world of self-funding, if you're funding too much, but you don't spend it because it doesn't happen, you get to keep your money. That's good news. So preferred provider organizations have begun to find real challenges in the market. And in fact, over the last 10 years, and more specifically 6-7 years, and now at a much more intense level today in the last 2 years than ever before, we're finding a departure from the PPO market into other ways to pay hospitals and facilities, because they can't keep paying them the way they have been, because it's just not predictable and it's not reasonable.
Before you get deeper into this, Rodger, you wanted to share with us some numbers that you captured about how this is causing some difficulties for people. So can you talk about those numbers a little bit?
Well, yeah, and this is something I want to show you that it might be difficult to read on your screen, but I'll read it for you. It's a little blurry. I thank StarMark for this, and CoreSource and AMPS, of course. They're the source of this data. But this data, these are real occurrences of real hospital bills that were captured by a company called AMPS during a repricing and hospital bill audit mechanics that conceivably in a PPO environment, no one would have been able to do anything about it because the toothbrush was provided. This was the charge for the toothbrush, and you get a 50% discount, and that's it.
Not a toothbrush, Rodger. According to your chart, it says an oral cleansing device.
Oral cleansing device billed at $1,050.
That's 1050.00.
Right, and that's a toothbrush. And then they had a mucus recovery system. Which,
that would be a tissue.
That's a tissue.
A common brand of those would be Kleenex.
It may have been a whole box of tissues. I don't know.
I don't think it matters when it's $75 for the recovery. Yes,
exactly. And then, of course, there's one of those pillows that looks like a travel pillow, right? Yes. It's just like a horseshoe shape, and it's called a cranial support system. You can buy it in any airport in the country at airport prices for 30 or 40 bucks.
Worst case.
You can buy it at a discount store for 12 because I just bought one. And the hospital billed $450
for one of them.
For one of those cranial support systems.
And then the last one I see there, Rodger, I believe that's an acetaminophen tablet.
I think all these bills gave somebody a headache. And so the acetaminophen tablet was billed at $513.23.
I like the 23 cents, which gives it an air of real calculation.
Right. But what it also, that would be for most people, that's probably a lifetime supply of over-the-counter acetaminophen. Right?
I would say, yes.
I mean, come on. It's so
or a couple of episodes of this podcast worth,
Right, exactly. Yeah, for those of you listening and getting a headache just today, I don't blame you, and I apologize, but that's the way it is. So anyway, when we look at these numbers, Bob, I've got Jill on the screen saying there's no way.
Okay, well, and Jill, I'm looking at these numbers, and I vetted this with Rodger beforehand because I was a skeptic, and I've got a little bit of a journalism background, and we checked this out. This is legit, and this is just what we saw. It could be. And these are just the ones they found and they shared. I would guess there's plenty of other ones.
Exactly.
Maybe not as bad or potentially worse.
Well, these are just samples. Like the one I mentioned earlier about the $940 titanium pin or whatever, $900 and change titanium pin was actually billed to our health plan by a Florida hospital at $34,000. And when we went to them to talk about it and negotiate it, they said exactly what I suggested. They said, I'm sorry, we have a PPO discount. The price is $34,000. You pay us 30% off of billed charges, and we don't want to hear from you again. So that's how hardline they were taking this potential discount. So in essence, it's giving them license to charge whatever they want and discount it.
Right.
So I think that's probably, I don't want to use a famous department store's name, but it's, but I'm going to. It's kind of like the Nordstrom's discount, right? If you're on the top floor of Nordstrom's paying for medical care, watch out.
Right.
So
if you go to the bottom floor in the rack, you might get a better
That's deal. Right. And you're going to get the same product. So the reality is you have to look at these things. And so as we move forward today, we're looking at value-based reimbursements.
We being who? Just so I'm clear.
The industry and Benefit Indemnity. And we're building products around what we call value-based or reference-based pricing, means to pay the hospital a different way. What you see on your screen today were caught because they were being paid a different way. They were paying hospital cost plus. Right? So they look at the hospital's actual professed costs for things.
Key being professed.
I'm sorry?
The key being it's the professed cost. They say that's their cost.
Well, not only do they say it, they swore to it to HHS, which they're required to do. If they ever provide
the U.S.
any
Health
service,
and Human Services.
Right. Health and Human Services requires that any hospital that ever provides services under Medicare must disclose to the government what their actual cost of these procedures are. And some hospitals are disclosing 20,000 different procedures, all with charges and fees. So they have to profess this, and then they have to have their CFO sign an affidavit to that effect.
So that document would be an accurate depiction of the price, probably.
No, that's an accurate depiction of their cost.
Their cost being what they want to obtain
No,
in
not their price, their cost. This is what it costs the hospital to provide that service.
the hard cost,
Hard cost. And then they need to mark that up
like any business.
like any business in order to keep their doors open and make a profit. And the average hospital profit in this country is around 12%.
Okay.
So some people are saying 12% is the fair profit margin on that. So we can mark it up 12%, or we can pay you cost plus 12, or we can pay you Medicare plus 20, or Medicare plus something else.
Because Medicare is often lower than.
Right. Medicare is a lot of times is lower than the actual cost even. So that's why hospitals charge retail patients more to help offset that cost shifting from the government. But the point is, what they're charging nationally is closer to 350% of Medicare on average. Their actual charges, which are astounding. Now, what they get is what the PPO will then pay them, half of 350%.
Which is still
175% of Medicare, and by all indications, 140% of Medicare should be more than adequate.
So this goes back to something you said to me, I'm going to guess probably 10, 12 years ago, which is we will not figure out healthcare until we focus on cost. Well, do you remember saying that to me? I was interviewing you for an article. I know this because I saw a clip of it a couple weeks ago. And you said that to me, and I remember thinking, well, this is right around the time of healthcare reform, and we're focused on cost because we're passing what has now been known as Obamacare. And so now here we are 10 years later almost, and we're coming back around to this whole issue of cost. And you hear politicians from all sides starting to say that it's not about the care, it's not about the number of people uninsured. It's about cost now, and we really need to move in that direction. It sounds like you're actually driving us in that direction with what you're talking about today.
Well, it's true, and I've been to several conferences just in the last couple of months that everyone within the insurance industry that means anything, and anyone that's really trying to make a difference, is looking at the spend. Looking at the total healthcare spend. And what that means is the appropriate pricing, the appropriate costs. One lady from a medical management firm, her name is Deborah Ault. We call her Nurse Deb affectionately. She's a nurse and she runs a medical management team. And she concentrates on what she calls the 5 rights.
What's a medical management team? You lost me there. Sorry.
Well, a medical management team is somebody that looks at a population of people covered by an insurance company or a self-funded health plan, and looks at that population and works to help control their healthcare costs by managing healthcare. So, for example, a good medical management firm will actually take your claims data every month, scrub it through the system, and they'll know if a diabetic isn't taking their insulin.
Okay,
and they can
because
pick up
the cost will go up, or
no, because they don't see the claim for the prescription.
Okay,
right? You're taking insulin for 3 months, and all of a sudden, you didn't fill your prescription for another 2 months.
Okay.
Now you're looking at a recipe for disaster.
Okay, because the care when someone goes off of insulin becomes so much more expensive when they're in the hospital with diabetic ketoacidosis.
Well, not only that, but I had a best friend that died from diabetes years ago. Best friend grew up through high school, and he was a terrible, terrible patient. He was non-adherent. And sometimes when his blood sugar would get low, he would use a Snickers bar to adjust it instead of insulin.
That's probably not the best methodology.
Not the best methodology. And in fact, it was such a bad methodology that one of the days he did that, he passed out behind the wheel, had a significant accident, and ended up in shock trauma at a cost that was so much more than treating diabetes. And so these are real things. So a medical management firm is going to really look at your population. They're going to call your doc. They're going to call you. They're going to reach out. They're going to say, hey, I noticed you aren't filling your insulin. Is there a problem? Is it about money? We can help. Is it about this? We can help. Are you not tolerating it for some reason? Did you break a needle in your skin and you're afraid to do it anymore? Tell me what's wrong, right? And let's get this fixed. In addition to that, when you go into the hospital, they'll manage that and make sure you're getting the appropriate care.
Okay.
But in any event, what I was getting
And is
to is,
that an additional fee if I'm self-funded? Are you charging extra within your system for that, or is that
well,
wrapped in, or how's
virtually
that?
every self-funded plan has a component of that, and there is a charge for that. It's part of the administration of the plan and part of the, usually a TPA will either do that themselves or they'll align you with a care
But it drives
company.
your overall cost down. So whatever
Absolutely.
that cost is, it's to your benefit.
That's right. It doesn't matter if you pay $100 a year per employee to manage costs if it saves you $500 per employee.
Right. And it sounds
Right.
like it could with one good diabetes case.
That's the mission. So what Nurse Deb's mantra is she's got 5 elements, as she says. You got to have the right patient, the right treatment, at the right time, in the right facility for the right price.
Wow.
And that element is what we really need to drive into all of our healthcare. So as we build these plans, we also don't want somebody running to Johns Hopkins Hospital or shock trauma for tonsillectomy.
Right.
Right? It just doesn't make sense.
Or the
Not
people going
anytime.
to the emergency room when they have a cold.
Yeah,
And we get this every winter.
and the number of emergency room visits that are unnecessary is professed to be anywhere from 70 to 80% of emergency room visits should not have been.
Which is why we have the urgent care centers going on practically every street corner, but you still don't see them being used to the level they need to be.
Exactly. And even the urgent care centers are used more because they cost twice as much as a primary care office visit, which is the appropriate alternative for the vast majority of these things. So, but we're all guilty of it. We put off getting care until it's too late, and now it's the middle of the night and we feel terrible and we're scared and we run to an urgent care center if it's open.
Or we don't want to wait for the appointment at 3:30 with our general practitioner when we can go to the urgent care center at 9 a.m. and sit there for an hour and get in and out.
Exactly. So here are the alternatives that we need to talk about. When we build health plans, we need to look at appropriate medical management to really triage and direct care. We need to look at a really good telemedicine component so that people can pick up the phone and make a call. We probably want to start looking at employee assistance programs more than we typically do, especially in the small group world. A lot of large groups do that. But you can defer a whole lot of mental health counseling and substance abuse and a lot of things with some real easy telephonic, or even now everybody's Skyping it. You do FaceTime with your counselor, so you get that personal feel. You're right there. I get it when I call my grandkids, so why not get it when you call your counselor? And so
Are you suggesting, Rodger, that your grandchildren are your counselor?
Yeah, they're healthier than most.
I just think it's great. I saw your grandkids today. I think they give you great counsel.
Hey, they're better than most of my hobbies anyway. So
wow.
So these are the things that we all need to really look at is driving new ways to deliver that care, to get healthcare delivery for the right call. Again, right patient, right time, right place, all of those things that so many of us kind of forget about in a given day, and patients in general forget about it during a given crisis. So what you'll see in our portfolio of products as we keep building, we have some already in place, and we're building a couple of new ones that I hope to have a plan very soon dedicated to a nurse manager managing your care from day one. And forget the network. You don't have a static network, because a static network gives you an encyclopedia of providers for you to choose from when you have no idea how to choose. And what most people don't know is when the insurance company gives them that book of providers, there are providers in that book that will charge $700 for the same procedure that another provider also in the book will charge $7,000 for. And there's no quality metrics, and it's a shot in the dark for the patient because they don't know. So instead, we're going to build a network that's not static. You call the nurse, you present your systems, your condition, we go through a process, we learn what you need, we talk to your doctor, we talk to the appropriate facilities, and we direct you. We build you a network. These are the 3 best providers in your area based on quality, outcomes, and pricing. So you can now choose from 3 that are logical decisions instead of 23 that's a crapshoot, dartboard. So now what we're going to do is build an appropriate network around you every time you need care. And it's going to be different if you need a liver transplant versus a kidney transplant versus heart surgery. There are different hospitals and different facilities for those things that have entirely different track records that our American population, we don't always recognize it. We don't know that. How do we know that? We follow what the doctor says you need this, you go.
Right.
Nurse Deb will tell you every time we have a conversation that 30% of cancer diagnoses are wrong.
Wow.
30%. Many of those have chemo started before they even realize it was a misdiagnosis in the first place.
So, Rodger, we have a question from Stevie. I don't know if Stevie's male or female. I apologize, but he or she says, I'm a small business owner. This sounds really good, but isn't it going to be more expensive when you don't have that set network and set prices already built in? So, yes, the set prices are more expensive, but what is the price mechanism that you're going to use when you build this network, I guess?
Well, when we build these dynamic networks, what we're going to do is go out and talk to each of these facilities. We're going to find the facilities with the best quality, talk to them about how we reimburse and reimburse them appropriately. In Maryland, for example, hospital fees are set. So it's more about telling you which hospital is the best, not what the price is going to be, because the rates are fixed by the government.
Okay.
And so that's okay there. In other states, it's all going to be about looking at the professed cost that hospital is saying to the world, this is what it cost me to do this, and then paying them a reasonable profit on top of that and negotiating your way through that process.
So with your, I'll call it an ad hoc network that you would build for each case, you would get the rates set in advance. Before I had the heart surgery, your nurse would work with me to figure out where and what and all that stuff, and the price would be clear. And the price being charged to me for that procedure might be different than the price charged my neighbor who had a different set of circumstances and went to a different hospital. But in both cases, you'd be driving to get the lowest possible price for the highest quality of care. Am I understanding it?
I wouldn't say the lowest possible price,
Okay.
but certainly the highest standard of care for the most appropriate price.
Okay.
Right? We're not trying to have hospitals lose money like Medicare does.
Okay.
We're trying to pay them appropriately, but not excessively. And so appropriate pricing is really what we need. And transparency, and the president, whether you like him or not, one of the nice things he's done is he signed an executive order demanding transparency so that finally the hospitals and the insurance companies have to tell you what these costs are and what these prices are. And so that's a huge step forward in helping every American consumer be a better consumer for healthcare.
And it sounds like that transparency really enables you to build these ad hoc networks a little more effectively. Is that correct?
Well, that transparency certainly gives us a lot of latitude. Yes, it gives us a lot more open discussion with a hospital billing administrator or CFO, because now they're like, well, I have to disclose it, so I might as well talk about it legitimately. Right?
Okay.
Let's have an intelligent conversation about how to get paid appropriately for each patient.
Okay. And you said you were going to put together this sort of ad hoc network in Maryland. Will it be in other states as you roll it out, or is it unique to Maryland because of the healthcare issues in Maryland and the way they do their pricing?
Well, I will say to you both. We're going to roll it out in Maryland first because of the hospital billing structure in Maryland, and it makes it really appropriate and necessary in Maryland.
The need for it's more acute in Maryland is what you're saying to me then.
Well, I would say not only is the need for it more acute, but it's the only thing we've got left in Maryland. There's not much else we can do.
Okay. And
right?
Maryland's your home state, and you've been dealing with this in Maryland for over 30 years, so you know it
right.
more intimately.
Exactly. But at the same time, this concept of delivering a network of providers based upon your condition. Now, keep this in mind. When you have these companies that do millions and millions and millions of dollars worth of claims data collection and research, and they do something called predictive modeling, they uncover things. And when they uncover things that many of us have seen these things, but believe it or not, you might be in a different hospital for the same condition as your neighbor simply based on your age difference. Now, it's easy to say that when you got a pediatric hospital versus an adult.
Yes.
But what about a 25-year-old man versus a 50-year-old man? There still may be a difference. And there may be a difference between race. there are different races that have different conditions that respond differently to certain treatments. So an African American male versus a white female could have entirely different responses to the same kind of medication or treatment. And so when you look at these things, building the appropriate network, instead of saying to a patient, here's your book, take your choice. I mean, that's the most ignorant and obnoxious thing I've ever heard. In hindsight, in the original days, we're like, okay, great, here's our network. Now we know where to go. But you don't know where to go. All you know is the million options that you have.
Right, you're flying blind, really. It's either
completely.
pick or a friend of yours tells you they have this person.
Or your doctor tells you this is the guy he plays golf with on Wednesdays, go see him. None of that has any quality or cost metrics to it or not.
Right.
And so those are the things that we all need to address. And so when we talk about PPO provisions and we talk about different things in the world, the alternatives are coming on stronger and stronger every day. And frankly, I don't believe 10 years from now that the PPO will be recognizable in our marketplace.
Wow, you made a crazy pronouncement 10 years ago and it turned true. So now you can come back to us in 2029 and see if Rodger was right.
Well, let's close this with one other thing, Bob. I don't see any more questions on the screen, but let me tell you why. There are about 175 million Americans on private health insurance plans. Okay. Let's say 100,000 of them are on PPOs. It's probably a pretty good number. Do you know what a PPO charges you to use their network?
Yeah.
If you're a self-funded plan, one of the big PPOs might charge you $14 per employee per month for that book of discounts, for that book of providers that gives you a discount. Now, take 100,000 Americans times $14. What do you get?
A lot of money.
A lot of money. A lot of money.
You're making me do math. That's
so
not
if
allowed.
you take 100 million times 14 times 12 months, and you can pretty well say that we as a nation are spending $14 billion a year on a coupon book, a discount book.
That makes those entertainment books that were available 10, 20 years ago for $20 a bargain.
Buy one, get one free.
That's
exactly.
Right.
That's the problem. PPOs are a wasteful venture compared to transparency and appropriate pricing. Now, what we have today is a similar cost in achieving that transparency and appropriate pricing. It's just doing it a different way, but it still costs about the same. 10 years from now, that cost won't be the same. The transparency will take root, will make sense, and people will know. The data's there, the modeling is there. All we need to do is save the American public $10 to $12 billion a year, just on that. And of course, at the same time, we'll probably save 50 times that in medical costs by paying the appropriate charge.
And the care will still be as good, if not better.
Probably better. Probably better.
Well, it's amazing we could drive down costs and drive up quality of care in the same.
We have to drive costs and bend the curve on costs and continue to maintain and improve quality. And we're going to do that with a whole lot of companies. You'll hear more about them as we keep doing these benefit roasts each week, because you heard a little bit about Nurse Deb this week. You'll hear more about Armada Healthcare. You'll hear more about other firms as we go that are actually out there every single day studying who is the absolute best knee guy in Baltimore and in Washington and in New York and in Dubuque, Iowa. Right? And they're going to find the providers that are delivering the most appropriate care for the appropriate price and get better care for less money in the long run. So that's what we need to achieve.
Wow. No lofty goal right there, huh?
Well, it's lofty and it takes time. But we only get there if everybody on this call and on future calls and in all of our discussions understands and can push right alongside us to get there.
And I think you've created the pathway. It makes more sense here than if you had just said, hey, in 10 years, it's going to be completely different. So I appreciate that. Thank you for explaining the PPO situation far better to me. And if you're looking at this or if you've been participating, we want to give you a cup of coffee for taking time out with us today. You can go to the link that you see on the page there. I am not going to read it to you because it's way too long. If you can't find it, you can call Rodger and talk to him. If you have questions about PPOs or about your benefits, he'd be happy to talk to you. I know I have meetings with Rodger all week, every week, and he will stop a discussion with me to take a call. He really does answer his phone. What's that number again, Rodger?
If you'd like to call me, it's Rodger Bayne at 443-275-7412, and that's the direct line right to my desk. Be happy to talk to you anytime.
Thank you, everyone. This has been really great. We'll be back next week with another Benefit Roast. Until then, be healthy and safe.
Thank you, everyone.
You've been listening to the Benefit Roast, a weekly discussion sponsored by Benefit Indemnity Corporation. Employers in a wide range of fields are using employer-owned health benefits plans to deliver better benefits to their employees at a lower cost. Learn more at benefitindemnity.co. That's benefitindemnity.co. See you again next week.